Hello everyone, myself Dr. Dilip, greetings from Medica Hospital. So I am going to do a zero or ultra low contrast PCI today, and this is a patient who had acute coronary syndrome, and we did the angiogram today morning, and we can appreciate LAD diagonal disease. Diagonal ostium doesn't show much disease, but LAD there is a critical narrowing. There is a narrowing in the OM and high OM and circumflex, and RCA also shows mid RCA borderline disease. So my plan is to go all the way imaging guided everything. So we will do imaging guided femoral venous arterial puncture, and then we will go IMS guided PCI. So you see here, you can appreciate 3 barrels. So one is femoral artery, the medial one is femoral vein, and the lateral one is profunda. So we will go little up. Okay. So now you see here, you can appreciate the femoral artery well. Basically, you see, you can appreciate the local anesthesia I am giving is splitting the plane. Okay. Now I will go with the puncture. So we can do with micro puncture, or we can go directly with this. Okay, you can see here it's coming. See the same line, and you see. You see the blood now coming, okay? Okay? Joanna. Now should not happen any problem. Give me 7 French guiding catheter, okay? Saturation is 89%, give oxygen. This is a very crucial step, engaging the guide catheter without giving a contrast. So you see, this is a 20 ml Normus line, and the movement of catheter is very important. If it moves with your coronary, then it is you can appreciate that it is there, and it can confirm with the changes in the T wave. So this is really an important step, okay? Or sometimes your guide, we can directly take guide wire, and but that is a little risky, okay? So you can just give this a line. Okay, so you see the ST changes if it is happening? No. And it is more challenging when you are using a 7 French guide. No, I think we are there. So we can take a coronary wire then, okay. 7 French guiding catheter you can't play and take chances. So pulling, pushing. So better to go with a coronary wire if you are little okay that it is somewhere near. So now go to spider view. So and you don't have to go any you have to overcome any resistance. Go epicranial RO. So you can appreciate we have not given any contrast till now. We have engaged it with our idea, and we have taken the coronary in. The angiographic picture should be there in our mind every time, and we will first wire the LAD, and then we will go to diagonal. You see here, you have to reach to the crux and to the mouse stage. So you can't take chances here, that is LAD or diagonal. So we know the coronary anatomy of this patient. So we are pretty sure that is in LAD, okay. So we have checked the ACT, it is around 210. We have given extra heparin, so we'll keep a watch. Now we'll go to diagonal, and then we'll image it. Anytime patient complains of chest discomfort, we'll do a contrast injection, but if the patient is comfortable, we are comfortable again. Okay. So we had 2 diagonals. The diagonal which is close to disease goes a spider now. Is a larger one, and it is almost going parallel to the LAD. So this one will give us an idea, and the meticulous study of angiogram also shows there is another diagonal coming, but that is going little up. So we have an idea of the coronary anatomy. So here you see now. So go epi. So wiring in the desired branches is the first prerequisite of zero contrast PCI. You see, I think this is the diagonal which is coming from the lesion. Okay. So now we keep it here. We'll go with the IVAS. You see, give me the IVAS. And when you have not dilated and you have to put 2 wires, always hemodynamics needs to be there in our mind. So come. Okay. So we have crossed, and now we will image and take all the information from here. So you see here the vessel size is not very great, and it is a diseased vessel. And the segment which we are feeling that is okay, is also diseased. You see. And now we have to take cine, where there is a basically a disease landing zone. So we will take it again if needed. So we are near the disease segment, and you can appreciate there is a little calcium here, and this is the tightest part. And here the frame, everything gets static. It should not move because the landmarks you are taking. So maybe proximal. This is a good landing zone. I am taking a scene, you see. Okay. This is again a branch here, and we are in the probably left main. There is a little disease there. Okay. So left main is also little diseased, and now we will okay. We will take it out. So the vessel is around 2.5 maximum distally, and can you measure the length? The cine which we have acquired is the proximal segment. So if we measure the length properly from IVUS, and we deploy the cine image where we have kept it, it will be doing our job. So now you measure the length from starting. 24. So we'll take something around 26, and we'll take 2.5. Will go up, and now we will do a balloon. So give me a balloon here. Okay. We'll take a 2.25 balloon, dilate it. Okay, down. There is a calcium we saw. Dilate. Okay. Okay, go. 16, 18. Okay, down. So now we will take the information. We will again review the angiogram which is there with us. So as the angiogram which is there in the monitor here. If we have any concerns about distal landing, we will take the IVUS again. Okay. So from diagonal, these all segment looks okay, normal, the same. So whether you place here or here for fluoroscope, it doesn't matter. So we have seen the IVUS. So we go with the IVUS image which we have got. Okay. So give me the stent. I am not going to do IVUS again. I will do stenting, and then we'll do a dilatation, and then I will go with IVUS. Give me a stent, 2.5. So we'll go 2.75, deploy at low pressure, and then we come out and we'll see the IVUS and decide accordingly. So that cine image is very important, where we had taken, and the patient is fixed, the floor is fixed, and then we will deploy here. Go back to the proximal landing zone. Go back. Quickly. Here. You see, right. Here. How much distance? 24.5. 26. Give 28. 28. Okay. So we can't go high pressure here. So it is coming like 24.5, 25. So we are going 3 mm extra. 10 is all right. Take a scene. Okay. Down. Down. Now we will what we'll do is we'll do IVUS. We'll see how things are there. Okay, give me 3.5. Okay. After pot, we will see how things are there. Go. 12, not more than that. Okay. Now down. Now I will do a IVUS and see the diagonal, how the diagonal looks like here from here, and then we'll decide. We'll recross maybe it needed. Okay. So now we are across the stent. We'll image now. Yeah, a little bit. Yeah, see landing zone was perfect. Okay, and the stent has landed proper place. So always good to have some extra length, 1 or 2 mm, and not to be very tight in that situation. And see, it's a good MSA we have got, and it's a fairly expanded stent. No gross under deployment. Here we can go a little high. Where is this? Okay, just after this bifurcation. Okay. Now we will see this diagonal is coming, and you can appreciate diagonal. You can see here is there was a reasonable reasonable lumen looked like there. So we can go little high pressure here. Okay. Okay, we can go with 3.5 high pressure here and 3 distally. So in the meantime, what we'll do is we can bring the wire recross the diagonal, and then we do that rest of the post dilatation. Okay. 7 French catheters are really little dicey because they are little unforgiving if any problem happens because of guide. So we will cross the strut here. So somewhere here, yeah. Yeah. So we could easily cross it. So plan of the RCA is what we'll do is we'll do IVUS first. We'll look at the MLA. Okay. If it is less than 4, then we can go for a FFR or we can do some stenting there. Otherwise, we can leave it like that. Okay. So diffusely diseased vessel. You see distally how pathetic it was looking. Now there was a good lumen here. Now we are approaching stent. So the artery has a little grown there also. It's okay. So distal segment also will give some little, okay, 3. Now you see now it looks good. So diagonal you can see the flow. Okay. I can take my IVUS to diagonal also, we can see here. We'll try to do that. Okay. Give me diagonal on the diagonal wire the IVUS. So we are fairly okay with the expansion. Okay. Post proximal to diagonal stent deployment. Flush it. Proximal to the LED, diagonal, go. So it looks good, huh? It's not going. So anyway, it's not going. So we will not jeopardize this. Okay, we can dilate it, but before that, give me the 3.5. So what I am going to do, I will take a shot finally before coming out. Okay, this is more than 8. 8 is okay, है ना? 8 is okay. So I am going to take a shot just to see that things are fine. Give me a Nicorandil. So we are fine with that. You see the diagonal is flowing, and only one view we have taken. You can appreciate in the IVUS also. You could see that the diagonal, the flow which was earlier there after post dilatation, we can't see that brisk flow there. You can see the movement. And now I am giving saline 20 ml, and now we will see the ECG also for T changes. Give me saline 20 ml. Such a gross ST changes happening with 20 ml of normal saline. Now you see I am taking the RCA wire, no contrast. Okay. So you have to take into the main RCA, and you can confirm it with multiple views. So you go LAO, cranial. So what is last ACT? 251, so you can appreciate now in the RCA. So 268 is the ACT. Okay, don't give now. Okay. It is touching the wall, guiding catheter, and we have to be little non-selective while doing that. Okay. So we'll take the IVUS now directly. So let me go inside and come forward. So there is no resistance in IVUS movement. And now let us show the IVUS. Okay. So the patient's ejection fraction is less. That's why our angiographer did not give much of contrast, more of you see here there is a disease, there is a side branch. So this is a screening view we are taking. If we find that this is a disease, we are doing something, then we will go for a manual pullback. So where we can stop, we can take a scene image, we can study that properly. So all along we have got till now no reason to think of any stent. Okay, so this is a good lumen, and you can appreciate there is absolutely no FFR needed. So what it appeared in the angio, maybe because of the only one shot which we took. So it's again a authentication that IVUS give you so much of information, and you can do away without any invasive work. Here there is a plaque, proximal RCA, and here I think our catheter was abutting, and we were not getting good pressure dampening was there. But the MLA was not very bad. We'll measure it out. So the ostial, this is the ostial segment. There is some disease. Okay, so there is ostial plaquing as well. Okay, so now we are in. So very important information we have got through our IVUS here in RCA. Very important. Okay, what is the MLA here? 3.7. So let's go with a FFR. Okay, give me FFR where? Yes, 3.7 is not bad. It is closer to 4, and 3.8 it is there. Yeah, 3.5, 4. It's a very borderline. IVUS FFR shows the FFR. Okay. Okay, so I will remove that one now. Okay. I am equalizing inside the aorta. Oh, yeah, it has gone. So, no problem. Show me down. Okay. Let me equalize it first. Okay. Do equalization. Yeah, introducer out. I see the movement again, and I will go inside. Adenosine ready? Yes, sir. Okay. So the idea is when there is a disease. Okay. So now it has gone in. We will keep it here. Okay. So it's 0.78. Okay. So it's a positive. So now we have to look for which lesion is positive. So what we'll do is we'll review the IVUS. You remove it. Okay. We will work on this. We will fix the proximal segment. Show us the distal disease which was and how much MLA was there. 4.42. Go back. Go proximal. Go proximal. We have to treat the proximal segment. Okay. And then we will repeat the FFR once we are done with proximal segment. Okay. So we'll take the IVUS again to just see the landing zones. Okay. And here it is very important because we will give an extra wire here. Okay. Go inside. It is all okay. Okay. You see. So it's all okay till here. Okay. So I don't intend to go down all the way. So it is okay. You see. So this is the place where I wanted to deploy the distal stent. You see, maybe this is a disease. Okay, so we'll go little down here. This is the deployment segment. Okay. So here the movement will happen. So okay. So now automatic pullback and measure the length. Automatic pullback. So 24. I will take 24. Okay. So give me another wire. Okay. So we'll keep it in ostium so that it will allow us a little more better positioning. Okay. Okay, we'll dilate here. I think this is here only. Show me the scene again. Previous one scene where the disease, where landing zone was there. This is landing zone, huh? Okay, huh? So we'll go here. Okay, go. 12. Down. So there is one important aspect is when go again. Go. 16. Down. So if in a 3.5 vessel, if you are going with a 3 balloon, nothing, it doesn't cause generally injury. So go again. So you should be very relaxed with that. Down. Okay. So give me stent now. Okay. Now it's okay, I think. Okay, you can little pull it further. Okay, it's okay now. It's okay probably. Okay, so we have good. Okay, go ahead. Deploy.
Going, sir.
Deploy. Deploy. Deploy.
6,
Yeah. 10.
10, sir.
Okay. Down.
10.
No important. Now in the lot terminal, just remove it. Okay, we'll see how things are behaving. Okay, give me 3.5 balloon. I will post dilate and then I will take how much. Can you show me the size again? The IVAS 14. Down. So we are working on FFR wire only, and we'll see how the FFR turns up at the end of the procedure. Okay, leave the wire. Okay. So you see there was some plaque here, so we didn't want to deploy here. We will little. So this was a normal segment which we targeted. Okay. Now probably our stent will come. So it's a normal segment which we targeted. Now the stent will come. So yeah, so the stent has placed in a beautiful place. Okay, so we can go a little bit high distal edge, and we have to see the ostium. So when we dilated, we left the distal edge. So that's what it was showing, and here we are is a good position here and a good MLA, good MSA. And it is ostial, you see ostium, we have to be, stent is still there. So stent is still there, see. So we are in the ostium, that is very important. And we can go little more, and the distal segment of the placement of the stent was perfect, okay. So where we try to land, so distally there was also a plaque. So we didn't want to go there because it would have been a very large stent, and nowhere that lesion was looking significant. And you appreciate everything looks so good here now. The BP is 130, 132. Patient is hydrated now. And now you see the dampening is not happening, which we were getting every time. So we'll take it little down. We'll give it. It should not be destroying the strut. You see 132, 74, heart rate is 71, no inotropes. We have done RCA proximal stent, seeing the just make it negative. And when we started, the patient had a low saturation. Now is okay, and his yeah. So I'm going with 3.5 balloon. So it is a same balloon. So it is open now. It may create problem. It create problem. Then we'll take a NY. So it went in easily. Okay. Okay. Go. 12. 12. Down. Go 18. Here there was a under deployment. 18, 20. Here we had gone only 16. 20. Okay. Down. So we are done now, and we can have a final IVAS look, and we'll do a FFR now. So FFR wire looks damaged, and there is a little challenge in the. So we'll take a final view and we'll come up. Okay. One injection of LAD and one injection of RCA should be more than enough. Oh, looking fantastic. Hold it. So that area we have seen in the IVAS, that there was you see here now in different frames. I'm happy with the result. Yeah. So this is the image one should look at, and we'll show you the MLA of that place. 5.8. So there is no point, no way it is going to be significant. So I'm stopping here, and now I will do a vascular closure of this. That needs to be demonstrated. Okay. So for final IVAS, we'll show it. So now I will do a vascular closure. These are very important. You leave the patient tension free from the cath lab. Okay. So we have seen everything is fine. Heart rate is 75, BP is 130, no inotropes. And now we have taken long wire here. And can someone come here and press? Always one should have a assistant there pressing, and this step is very important. Just press it hard, okay. So this nick, there has to be good entrance nick, otherwise your proglide will not go, and that will be a big problem, okay. So you see we have created a good nick here, okay. Now we will take that, just press it. So there are 2-3 important points. It has to be long wire, not a short wire, and the track should be properly dilated, otherwise your knot pusher will not go. This is very sophisticated, it will go. Now you see here the wire port, exit wire port. Now we remove that wire and we go in. Now you see the blood will come. You see the blood is coming. Now you make this up, withdraw, and you have to stabilize this, and then step 2 and 3. Now you remove this and make it tight, okay. Now you cut it, and once you cut it, go little down, again close it, and then come up. And once you are coming up, just hold, you remove the sutures. There will be 2 sutures, okay. So just press it little harder.